this is what we see, in a level 1 trauma center, right? So this is a young patient, let's say 40 years old, high speed motor vehicle collision. This is a Pilon where, a lot of foot and ankle surgeons would look at this and say, what is the point of reconstructing this? This is not going to work. This patient's going to need a fusion. Maybe you can wait a little while and get them a replacement later if the technology improves. Like I said, we're simple trauma surgeons. We see a broken bone and we say we should just try to fix it. And so you can see here, we fixed it, but high energy, open fracture, a lot of devitalization. It's not unpredictable that this goes on to a non-union. And luckily for this patient, I don't show all of the CT cuts, right? We have fairly good alignment. If you look at the non-united pictures, bottom right, you have to trust me based on CT that there is a functional joint. This patient is 40, he's very active. Actually, his motion was pretty good despite having significant pain. So instead of being able to walk much on his pain, he focused on motion. So he wanted to preserve that motion and we wanted to preserve it for him. So here we are, we take him and, we know we need to get bone graft, right? This is a bad open fracture, a lot of devitalization, not so much that there's a lot of gap, but we know there's a lack of biology that we want to provide him. You saw this in some of my partners' videos where you see top right, you see the actual bone, and then right next to it, you see that solution that you get with it. If you look at that graph that we show you there, those are thick chunks, right? I'm not by any means saying that this has compressive strength. That's not what I'm saying. I'm saying that it's real legit cancellous bone. It's not shredded, pulverized bone. We're trying to create what I have on the right there. We want cancellous bone. We want that kind of chunky bone. Well, when you have bone graft that has a little bit of structure to it, not compressive strength, but structure, it will fill that defect with probably less weight, but a better density of bone to actually allow vasculature to fill in and get this bone graft to heal. So you want to loosely pack it, but you want to have it filled so you have less dense, chunkier pieces of bone like you see. And then for biology, you can use what's below there. That's where the cells are. That's where the marrow contents are. And however you want to use that, if you feel like you need to expand your graft with some allograft, if you need to expand your graft with synthetic, you can use that to hydrate it. For us, we use a lot of antibiotic powder and a lot of procoagulant powder, and we tend to hydrate those substances with this. Usually at this point using Avitus, I don't think I need a lot of allograft because I think it's going to make it too dense. I don't think I need a lot of synthetic, but I'll take antibiotic powder and I'll take procoagulant. I'll hydrate it with this marrow fluid and I'll use that to put it in. Sometimes we suck it up with syringe and squirt it in just so we have some of that extra biology in that space, right? So here you can see that graft, and in this one you can see some white flakes in there. That's the vancomycin powder. Again, we fixed it as such. You can see that there is still a joint, right? It's by no means perfect over in a post-traumatic state, but there is some joint space there on both views. We fixed it opposite. We placed the smaller plate, anterior and the thicker plate medial just to get a little bit different mechanics. And again, relatively easy surgery from a reconstructive standpoint because there's not a lot of deformity. We pack in the graft where we see fit, and all of a sudden, 6 months later, you can see, especially on the lateral cortex and the posterior cortex, we have pretty good healing, right? So again, the key is getting legit bone graft that's not going to flow away, getting it with some structure so it's going to stay put and it's not too dense.